and good evening from those in Asia. So on behalf of the ICU-DDR, I would like to thank you for attending today's event, Harm Reduction in the African Context. So we will start by a few announcements, and then it would be followed by the introduction of our speaker. So next, we will have his presentation, and lastly, the question and answer portion. May I please request all the participants to turn off their microphone during the presentation? And if you have questions at any point in time, kindly use the chat box and our speaker will address it at the end of his presentation. Our speaker for today is the founder and executive director of the Global Initiative on Substance Abuse, a non-governmental organization whom, among other things, promotes the development of addiction programs in higher institutions of learning in Africa. He is an assistant professor at the Department of Psychology, Virginia Commonwealth University, and a distinguished Hubert Humphrey Fellow. He is also an alumnus of the Harvard Kennedy School of Executive Education. He holds a Master's of Science in Addiction Studies and a PhD in Psychology. Our speaker has over 26 years of experience in drug control, part of which was with the National Drug Law Enforcement Agency, the lead agency for drug control in Nigeria, where he served in different capacities, particularly in drug demand reduction, before retiring into private practice. He is also the national president of ISOP Nigeria chapter and the assistant coordinator of ICU-DDR for Africa. Ladies and gentlemen, our speaker, Dr. Martin Agwogie.
Thank you so much, Verna, for that introduction. Can you see my slides?
It's coming up. Yes, sir.
Oh, good. Oh, great. Thank you. Hello, everyone. Thank you for joining us at this webinar. Good morning, good afternoon, good evening, depending on where you are joining from. So briefly, I'll be speaking on harm reduction, concepts, principles, and practice. And I will be using some examples in Africa. This is the presentation outline. So we'll be looking at all of this in details as part of this presentation. From historical perspective, harm reduction actually started in the 70s by activists. And of course, it was more of a controversial set of ideas because the idea of harm reduction was viewed then as controversial. And the activists felt there was need to challenge the global drug policies. For example, policies on total prohibition of drug use, criminalization of drug use, the war on drugs, then the dominant interdiction model, which were the drug policy or the major drug policies of the 70s. But harm reduction got its prominence in the 80s when the link between injecting drug use and the HIV was established. And then it was discovered that IDU promotes HIV transmission. So this gave a boost to the promotion of harm reduction initiative. The World Health Organization was actually the first major multilateral body to endorse the principles of harm reduction, and that was in the 80s. And then the United Nations agencies, for example, the UNODC and UNAID, showed some level of hesitance to the initiative, especially at the initial stage, which means the WHO keyed into advocacy for harm reduction even before the other UN agencies. So harm reduction has gained for kind of global network. The initiative has received some kind of global push or advocacy through network, and this has become some kind of global governance on advocacy for harm reduction. And at the moment, over 100 countries have now adopted at least one form of harm reduction. So the concept of harm reduction, of course, it is a part of a coordinated effort to minimize the harm associated with drug use. Of course, other aspects of drug control measures include supply reduction or supply suppression, as the case may be, demand reduction, and so on. So harm reduction is one of the coordinated efforts to reduce the harm associated with drug use. So it seeks to reduce the health and social harms of drug use to individuals and, of course, to the wider community without necessarily requiring that the individual stop the use of drugs. So what are the components of harm reduction? I have four major components here. The first one is the needle and syringe exchange program. This is where clean needle and syringe are issued or given to people who use drugs or who inject drugs instead of recycling syringes, which eventually exposes users to blood-borne diseases. So this is one of the components of harm reduction. The other one is opioid substitution treatment or opioid substitution therapy, as some persons may prefer to use it. This is where medications like methadone, which is, of course, is mostly used as one of the OST or buprenorphine, as the case may be. There is also an extension of this opioid substitution treatment, which is the heroin assisted treatment. That is more like to ensure that people who use heroin inject heroin don't use adulterated heroin. So instead of using adulterated heroin, they are now provided with clean, base heroin as part of substitution therapy. This is rarely used, but used when methadone and buprenorphine seems not to be achieving the desired results. Of course, the third component is the drug consumption rooms, where people who use drugs are supervised in a room. They go there, receive the particular drug they use or inject drug in a particular room and go about their normal business, then come back again for either another dose, as the case may be. And in some centers, especially in countries like Netherlands, it goes beyond sorry, I can see hand up. Is there any issue? Vera, please confirm, or was it a mistake? Hello, Vera, please confirm. I can see the hand is dropped already, so I
Yes,
needed to be sure.
Marty,
Okay.
go ahead, please.
Okay, thank you. Thank you. It's good you can hear me. I thought that maybe my attention is being drawn to something. So drug consumption rooms are provided for in some places for different substances of use, and the rooms are provided and the individuals are supervised. Then another component is the naloxone opioid overdose reversal. This is used where there are cases of opioid overdose. And of course, you have different forms of it, the patch, the nasal spray, and so on, so as to revive the individual who may have overdosed on opioid. So harm reduction has now been proven to be effective, and of course, one of the cost-effective approaches that contribute to the health and well-being of people who use drugs, and again, decrease the challenges associated with drug use and crime. Contrary to what was obtainable in the 70s and 80s, where interventions for persons who use drugs mainly abstinence. But in this case, harm reduction looks beyond abstinence, especially that there are people who, for one reason or the other, are not able to stop, or they are not even willing to stop. Abstinence didn't seem to provide options for such people, but harm reduction has come to address those areas so that at least their need or expectations are met. So still on the concept of harm reduction, it is in a simple way, it is come as you are, irrespective of the stage of an individual in the drug use or abuse, as the case may be, or whether disorder, or irrespective of the stage of the individual in drug use. It is come as you are, as against you have to quit or just say no. You have to quit or just say no more. There's more of a goal of abstinence, or abstinence as the only goal as far as interventions are concerned. It also looks at how and why people have relationship with drugs, or why people engage in drugs. In other words, it is not looking at the individual who use drug alone. It looks beyond the individual to the environmental context and so on. It also looks at the negative consequences that occur at any level of use. For example, whether it is at the experimental level, regular use, or at the disorders level, and it looks at this for each of the psychoactive substances, whether alcohol, cocaine, heroin, and so on. And again, looks at the environmental context. So it is a perspective and a set of practical strategies to reduce the negative consequences of drug use. And again, harm reduction is critical in keeping people who use drugs alive and as healthy as possible. So quickly, we'll be looking at 6 principles of harm reduction. Different authors have identified different principles, but I have decided to adapt the 6 principles as promoted by Hawk and colleagues. So we'll be looking at each of these principles as the guide the concept of harm reduction. The first principle I have here is the principle of humanism. In this case, providers are encouraged to value, care for, respect, and dignify patients as individuals, and do not shame or think less of persons who use drugs or persons with substance use disorders. In other words, do not look down on any individual, whether or not the person uses psychoactive substances. And in this case, particularly those who use psychoactive substances, no need to look down on them. Also knowing that moral judgment made against persons with SUD do not actually produce a positive recovery outcomes. So if moral judgment do not produce a positive recovery outcome, so why engaging in moral judgment? And in this case too, grudges are not held against persons who use drugs. Services are user-friendly and responsive to individual patient needs. That is the essence of it. So providers try to understand the underlying factors contributing to the patient's drug use, as against looking at the individual and faulting or criticizing the individual. Providers also accept patients' choices and not imposing their personal beliefs or a professional experience on the individual, especially that before now abstinence was the goal. So imposing one's wish or provider's wish is more like pursuing abstinence for the client or patient, whereas the goal of the individual may not be abstinence. So another principle is the principle of pragmatism. In other words, this is telling us that no one, no matter how good an individual may be, no one will actually achieve a perfect health behavior. As human beings, we all have our areas of strength and weaknesses. So it's making us to be pragmatic in looking at issues and reduce the aspects of being judgmental, as I mentioned in the previous slide. So health behaviors and the ability to change them are influenced by social and community norms. So this is also telling us that behaviors do not occur in a vacuum. Like I made reference to earlier, and we have to look beyond the individual who use drugs to the environmental dictates. Then also identify or help the individual to identify a range of supportive approaches, towards the harm reduction or recovery process. Then care messages about actual harms to patients as opposed to moralizing the issue of drug use, and also using the social standard to relate to the individual. Providers do not also expect that persons with substance use disorders will never use drugs or involved in risky drug use behavior. So while providing intervention, of course, one should have a balance, knowing that the person who uses drugs may not actually stop using drugs. So behavioral interventions encourages patients to reduce risk factors for drug use. So the next principle is individualism. In this case, every person presents with his or her own needs and strengths. These are assessed for each patient. In other words, individuals are related with in line with their areas of strength and weaknesses. So there are no assumptions made based on harmful health behaviors. It is the behavior or the consequences that the individual is facing at a particular time should be the focus of intervention, and not assumptions based on what other persons who use drugs might be facing. In other words, there are no universal application of protocol or messaging for patients. And providers also strive to understand the patient's experience and how to contribute to suboptimal health, then offer appropriate interventions. Then the principle, number 4 I have here is autonomy. And this is also making us to understand that even if the service or care providers are there, to make suggestions, help the patient or client to identify different options, individuals ultimately make their own choices about what kind of medications or what kind of interventions or what kind of health behavior interventions or aspects that best suit their abilities, beliefs, and of course, make them as priorities. Also, provider-patient partnerships are very important, as we all know, especially when it is a patient-driven care. So shared decision-making, and of course, both in learning from both sides. Care negotiations are based on the current state of the patient. I just mentioned that earlier. It's not based on what is anticipated, looking at what is currently the health situation of the individuals. And of course, providers may assess readiness to reduce substance use and provide patients with drug use cessation education, if that is part of the goals as defined or as preferred by the patient or client. So the fifth principle here is incrementalism. This is also making us or helping us to understand that any positive change is a step towards improved health. In other words, whatever step that the client or patient takes is very important, especially when it is towards a decline in the use of drugs, or a decline as part of reducing some of the health challenges. And it also helps us to have a good understanding that positive change usually takes time. In other words, the care providers and other professionals should have a good understanding and be patient with the patients of clients. So it is important to understand and plan for backward movement. Even though patients are being encouraged, to reduce risk of drug use, there are instances that instead of reducing the drug use, there could be increase. So providers should prepare their mind for such cases. And it is important to recognize that at times, all people experience, of course, negative and positive part of life, which of course is general when it comes to even other issues. Then providing positive reinforcement, of course, is very, very important. So every little step, towards a reduction in risk should be celebrated, and the client should be commended for that. So the last but not the least of the principles is accountability without termination. Patients are responsible for their choices and health behaviors. At the same time, service providers are not expected to fire or terminate meetings or appointments or interventions based on the fact that the patient did not meet set goals. You recall that under harm reduction, the goal of interventions are defined by the patient. So even when the patient says this and this are my goals, where they are not able to meet such goals, sessions should not be terminated, or the service provider disengaging from providing intervention. So individuals have the right to make harmful health decisions, and providers can still help them to understand that the consequences are their own. I think that is the much service providers can do as far as harm reduction interventions are concerned. So while helping patients to understand the impact of their choices and behaviors that are valuable, like I said, backward movement should not be penalized. Backward movement should not be penalized. So having said that, in summary, while considering harm reduction interventions, it does not mean that therapist doesn't see any consequences or potential problems with client decisions and drug use. It is not as if the therapists are not seeing danger or more dangers ahead, but the thing is, it is not about the dangers ahead, but it is how to provide interventions at a particular point in time to reduce the risk, irrespective of the choice that the individual made. So harm reduction means a therapist can see the client situation in more than black and white. As against, it has to be, according to professional knowledge and expertise. You have to look beyond your professional disposition to the disposition of the patient. And harm reduction may or may not be sufficient for a client, but at least it is a starting point to build rapport, encourage change, and of course, support efficacy. Even when, as therapists, you notice that harm reduction is not the best for the patient, but again, it is a starting point. So it also means that services should not be withheld. We have to meet the patient where they are, which is very important, and move with them, as far as they will allow us go. Move with them as far as they will allow us go, knowing full well that the decision still rests on them. So this is another way to summarize part of what I've been saying as the principle of or the principles of harm reduction. So if you look at this carefully, it's a continuum. Any step towards the right, is a decreased risk. for drug use. But any step towards the left is an increase, in the risk of drug use. So if you look at from excess down to abstinence, any step towards the right side, decreased risk, is a step in the right direction. So all of this, as we can see on the screen, and many more, are the goals of harm reduction. So as we look at this box, whichever one that is preferred by the client is an acceptable goal of harm reduction as far as the client or patient is concerned. At the same time, there are more depending on the preference of the patient. So in practice, how do we practice harm reduction? It is more like buttressing some of the principles, bringing it down or breaking it down to some practical terms. It requires a combined therapeutic model, both motivational interviewing and CBT, and it encourages curiosity and safety, of course, towards lesser harm. Again, we'll talk more about just say no, and you can see the no, K-N-O-W, just say no, as against just say N-O. There are differences between this. The KNO is talking about curiosity to have a good understanding of situation. The other one, NO, is more like stop, So, excuse me. So if you look at the no, for example, what and how much, what this is telling us is that you need to know, more like teaching the clients now, to know the potency of the drug being taken. What is the potency of the drug being taken? What is the quantity that he or she can take? And what is the limit that he can take? So there is need to know this. Why the use? It is important to know why the use, the function of the use. Is it to take care of withdrawal symptoms, or just want to use because others are using? These are some of the questions, these are some of the things that, the patient need to know. Also know surroundings, support and using context, place and people. Who are the people there? Who are the people in the environment where the substance want to be used or where the drug want to be used? Are there people that we encourage one to use more, or there are people that could come to one's rescue or help when situation gets bad? So these are things that the patients need to know. Then know their drugs. For example, if the patient uses cocaine, if the cocaine is adulterated, is he likely to know? So a good understanding of one's drug, and of course, having a good understanding of overdose risk and potentials for overdose for the particular drug that the individual has used. Then of course, knowing that there are individual differences and not trying to emulate others. Then provide accurate and unbiased information about drugs. That is having good understanding of the drug that the individual uses. Then these are tips under the harm reduction practices. Tips to care for self while using drugs. These are some of the things you also have to teach, the patient. The basic things that the individual needs to know. They need to eat while using drugs. They need to sleep well. They need to even monitor one's breath. They need to stay warm. They need to find love. All of this becomes part of the basics, towards assisting the patient. Then talk about tips for health. They need to get treatment for both physical and mental health issues, and ask for help where need be. Then the things that drive one use, and what are those things that put the individual at risk of use of a particular substance. Is it anxiety? Is it trauma? Is it a sense of not having a sense of belonging and things like that? So there are things like this that the patient needs to have a good understanding of, so as to help him or her to meet the desired goals. And of course, promoting movement in the direction of health, like we just shared in one of the last slides. Then taking drugs with others, making the context safer, making sure that every environment where one wants to take drugs is a safer place where an individual can get help at any given point in time. And again, prevent having good knowledge of how not to get overdose. Then safer drug, ability to identify adulterants. I just mentioned it earlier. And for those who inject drugs, the need to use clean needle and rotate injection sites, accurate shooting, how to shoot properly, and where there are pains, how not to at least continue, especially when one experiences pains, then change route of administration, and of course, including, for example, instead of snorting, why not try smoking, depending on which one is preferred. All of these are not to encourage drug use, but more like finding a safer way to manage people who use drugs ahead of other more positive interventions. Then settings, where and with whom, the using culture, how to reduce the risk of use, time able to administer, and hygiene. For example, individuals may have issue with timing, either morning, afternoon, or evening. So what should be the best time that the drug use will not have more consequences on the individual? And also the environment where one is using the drugs. I've talked about environment before now. Is it a place where one wants to quickly rush into and use the drug? That also exposes one to risk. Because in attempt to rush and in a hurry to use drugs, it could also lead to some kind of complications. Another question is one seeing the drug that one is using? If it's in the dark, for example, how do you differentiate between the what one was given compared to what one intended to use? All of this become very important when it comes to educating people who use drugs. Then homes versus outside in the public. What does the experience become? What does the experience say? What does it look like? Is it preferable to use at home or preferable to use outside? So which one would be more convenient or better for the individual to minimize the risk? And again, like I said earlier, if the substance is adulterated, should one be able to identify it and know immediately, and of course withdraw from it? And how might one be triggered? What are those things that trigger individual for drug use? Then avoid it and plan not to fall into victim of those triggers. Then reduce your use by yourself before entering into a setting. So if a patient is to enter into harm reduction services, the patient can as well try, on his or her own to attempt, any of the options, which one is more preferable, that is likely to work for the individual. And the person may be able to come and suggest that as part of seeking help. And when it comes to engagement with therapists, of course, the focus should be part of collaborative alliance, interpersonal safety, and so on. And of course, the therapist should not have preconceived ideas about the client, and also try to minimize ambivalence using the different range or menu of options. And we know that maintaining a collaborative stance also helps to identify goals, especially for the patients. So how do we promote harm reduction? How do we promote harm reduction practices? This requires building both local and international harm reduction network of civil society and healthcare professionals. This is very important. I talked about how harm reduction started by activists, so that is very important. A network between civil society and professionals. And this should be facilitated by robust communication between researchers and other stakeholders. Research is very important. Research findings can tell us, how effective a particular harm reduction strategy is, and so on. So this is very important. And it requires influencing drug policy change, from the repressive to public health approach, so as to accommodate harm reduction practices. You agree with me that repressive law do not have provision for harm reduction. So it is instrumental to note that governments are always reluctant, to adapt harm reduction policies. And that is the truth everywhere. In all the countries, or most of the countries that have adopted or that have adopted harm reduction policies, it was usually not an easy process. It is usually a very slow process, and they always think differently. But with the persistence of civil society, both local and international, and professionals, at least with statistical or research evidence, this eventually becomes very useful. So advocacy by civil society is strategic to harm reduction policies and practices. That is just the way to summarize how to promote harm reduction practices. So quickly, we now look at the justifications for harm reduction. Justifications for harm reduction. Harm reduction is based on scientific evidence and also with the understanding of the complex nature of substance use and substance use disorders. Scientific evidence over time has made us to understand that substance use, especially substance use disorders, of course, have been identified as a complex issue. And as complex as it is better we have a good understanding of how to work out of this complex situation. So promoting harm reduction, or one of the justifications for harm reduction, is that it is based on scientific evidence. Knowing that some users or drug users or persons who use drugs preferably do not even wish to stop, and they have reasons why they don't wish to stop. In that case, how do you address their situations? And help harm reduction helps people who use drugs to remain relevant to their families and work despite their drug use. So instead of an individual not being productive and not having a good interpersonal relationship with family members because of drug use, and harm reduction has come to address some of these challenges, why wouldn't it be considered? Then it also supports the development of individual drug use minimization strategies, and of course reducing drug use practices and achieve treatment goals. And one area that I've experienced over time is usually the conflict between people who use drugs and therapists, because of defined pattern of treatment that seems not to put individuals into consideration enough. So in that case, there's usually conflict between patient and service providers. But harm reduction helps to minimize the level of conflict between patients and the service providers. And it is also a form of give and take approach to drug use treatment. Instead of the professional, detecting, using his or her professional experience to decide the best option of interventions for the patient, of course, it's a give and take, approach. Then again, it helps to respect human rights. It helps to respect human rights and the wish of individuals. And because of the challenges associated with substance use disorders or addiction, if we may want to put it that way, which of course is a chronic brain relapsing disease, looking at the challenge and difficulties associated with individuals being able to stop, considering the different withdrawal syndromes and so on, it helps to break barriers of a sense of failure and fear of the unknown on the side of the patient, knowing that every step he or she takes is a step towards a reduction of risk. If eventually he or she is not able to meet further expectations, of course, he or she has actually started, to do or has started doing something, which of course is very important. So it helps patients to take responsibility to care for self while using, regardless of the drug use status. And it's been shown over time, like I said in the first few minutes of my presentation, that the fear of HIV transmission through the use of needle and syringes help, to promote, the harm reduction practices. So it's been shown to be effective in preventing HIV infections, especially among those who inject drugs. And contrary to misconceptions or myths that harm reduction leads to increase in drug use, in fact, that is not what science is telling us. It is associated with substantial reduction in healthcare expenses and even policing costs. Studies have been able to establish this. So harm reduction does not increase drug use. Instead, it helps, to reduce healthcare expenses and, of course, cost of policing, arrest, detention, prosecution, and so on. So one of the justifications for harm reduction, again, is that total prohibition and criminalization of drug use has actually failed to yield expected outcomes. So if total prohibition and criminalization has not yielded expected outcomes, so what is the way out? Then from historical perspective, abstinence has been ineffective. Pursuing only abstinence has actually not been that effective. So we need to complement other abstinence strategies. This is particularly that abstinence does not work for everyone. So this needs to be identified as one of the justifications. Again, it helps to keep people who use drugs alive, while trying to profile solution and, of course, reduce drug-related illnesses and so on. And it aligns with the tenets of medical ethics, that is beneficent and patient-centered. And of course, it brings people who use drugs into the mainstream healthcare practices. So, of course, it also improves physical, social, and mental well-being of people who use drugs. So, helps us to understand that one size does not actually fit all. A person who uses drugs that is alive is better than a dead one. So, it's better to be alive and under harm reduction strategies than one who dies because of no proper intervention or no other alternatives. Again, I will always emphasize this. The fact that one is talking about harm reduction is not minimizing the real danger associated with illicit drug use. So the dangers associated with drug use, they are there, but harm reduction is one of the interventions to address, the challenges. That is not to minimize the consequences associated with drug use. I need to re-emphasize that. So it helps to understand that relapse is not a sign of failure. So having looked at the justifications for harm reduction, so quickly I'll look at some of the barriers to harm reduction. And the first one here is drug control policy. I will use two countries in Africa as example how drug control policy can affect the implementation of harm reduction principles. For example, if you look at the National Drug Master Plan, the South African National Drug Master Plan of 2013 to 2017, if you look at it carefully, it defines harm reduction differently from how WHO defined harm reduction. In that master plan, it introduced a different version to it and termed it localized version of harm reduction. In other words, it's saying that how WHO defines harm reduction is too liberal for us to adapt in South Africa. Instead, we have to redefine it, to suit our purpose and refer to it as localized version. That was the 2013 to 2017 National Drug Master Plan of South Africa. But if you now look at the 2019 to 2024 master plan, they have now, South Africa has now adopted the WHO definition. So this was through pressure from civil society and so on. So the point I'm trying to make here is that how different countries decide to define harm reduction becomes a barrier to the full implementation of harm reduction principles. In other words, it becomes some kind of selective approach to harm reduction. That is one example. Another example is the drug policy in Nigeria. We have the National Drug Law Enforcement Agency Act of 2004. Of course, that law was through a decree in 1998, which criminalized drug use. That law criminalized drug use. And that law, as I speak with you, is still in existence, even though efforts are being made to amend the law. But you also know that how challenging it could be to go through legislative processes in amending laws and so on. So that law is still there. But if you now look at the National Drug Control Master Plan, which of course the current one, 2021 to 2025, it adopted the full complement of harm reduction. So if you ask me, there is a conflict there between what the laws of National Assembly or an act of the Parliament and drug policy statement. There's a conflict. So even though the National Drug Control Master Plan 2021 to 2025 has fully, adopted harm reduction, but the repressive law, which criminalizes drug use, is still there. So you can see how drug policy can affect, the full implementation of harm reduction. That is not also to say that efforts are not being made, to address this area. Because of the National Drug Control Master Plan policy document, pilots of harm reduction practices are ongoing in Nigeria, but again, in the midst of repressive and drug law. So you can see how that goes and the challenge it could pose. So other barriers, despite evidence of effectiveness of harm reduction measures, of course, it still remains controversial and highly contested in many countries. Of course, harm reduction still faces obstacles and barriers in many countries, both from government, faith-based settings, sociocultural barriers, and so on. And of course, the issue of stigma, associated with drug use, both from the side of the public and also the practitioners. So this stigma also constitutes barriers, to implementation of harm reduction. And this hinders the provision of adequate care, particularly to people who inject drugs. It creates problem, for them, both in terms of embracing harm reduction practices and also in terms of seeking help early enough. So the restrictive policies of drug consumption rules, as it is in some countries, also poses challenges or barriers to the implementation of harm reduction. In some countries, you see drug consumption rules acceptable for a particular, for example, OST, but not acceptable for people who inject drugs. So all of these are barriers to the implementation of harm reduction. Again, funding constraint. This is not unconnected with public perception to harm reduction. In some countries, for example, you discover that methadone and buprenorphine which are the major component of OST, are not on the essential medicines list, due to negative perception and misconception, and in some cases for political reasons. So people see, or by means or so, some people say that opioid substitution therapy increases the circle of addiction. And in some cases, they say it leads to overdose and so on, and that it is inferior to other treatment interventions like abstinence-based treatment and so on. Again, funding for harm reduction practices or promoting harm reduction practices have significantly reduced, especially with the reduction in HIV transmission. You recall that I said it earlier that HIV transmission using the IDU as an instance was one of the reasons why some political stakeholders embraced harm reduction when they saw the negative consequences. But now that studies have shown that the rates of HIV transmission and so on has reduced or is reducing, harm reduction practices have also reduced. Then in many places, focus is still on abstinence as against having to look at other components of interventions. So just a few slides before I end the presentation, then talking about language and stigma. This is also very important in providing a harm reduction intervention. The use of first-person language with accurate health terminologies, avoiding language that can be stigmatizing or accurate as far as professional terminologies or health terminologies are concerned. There are so many of these, but I just felt just cite these two examples: people with substance use disorders as against drug addicts and things like that. Abstinence instead of the use of clean. This person is not clean and things like that. These are stigmatizing terms. There are so many of them like that, and of course the terms keeps changing depending on preference at each given point in time. So relatively, all of these, as we can see on the screen, are daily pills to prevent pregnancy, the use of condom, seatbelt, speed limit, e-cigarette, and so on. They are all part of harm reduction. So it is not only in the aspect of the use of drugs, but they are also in different areas. So relatively, when we look at all of this, you discover that embracing harm reduction is not bad after all. So starting harm reduction plan. There is need for intake, screening, and assessment to look at where the individual is at any given point in time. Start slow and take it up, gradually with the individual without any form of rush. Then there is need to be patient and get all the necessary support. And it is important to say that, for each psychoactive substance or for each drug, there is need to look at them in details and develop harm reduction strategies. Alcohol has its own harm reduction strategies. Cannabis has its own. Other stimulants, heroin, they all have their own harm reduction strategies. For example, telling an individual to eat before drinking alcohol is all part of harm reduction. Telling an individual not to drink while driving, all of these are very important. So each of these, there is no single way to say, or there is no point saying that all the psychoactive substances have the same harm reduction strategies. All the substances have their own unique strategies, and not put all of them together with a single strategies. And let us not also forget that individualism, both in terms of the patient and what is being used, they are very important in delivering harm reduction practices. So in conclusion, I would say that for effective and sustainable harm reduction practices, there is the need to focus on not only on the individual behavior, but also on the physical and social space in which a person's substance use and other harms occur. And also there's the need to look at opportunities that exist within this space of people for people to reduce the risk. Then there is the need for the development of national drug policy that accommodates harm reduction as a component of drug use intervention strategies. And this, of course, is very important because it is upon the policy that you can actually evolve these strategies. Even though governments, are very reluctant in putting this into their drug policy document, but when eventually it is there, it gives foundation for stakeholders, both stakeholders to now develop harm reduction strategies or interventions. So there's the need to improve knowledge about substance use disorders, and there's the need to change public perception about people who use drugs and their harm reduction. So I want to say thank you so much for your attention, and the presentation will be available, and these are just some of the references that I have for this presentation. So thank you for your attention.
Thank you very much, Dr. Martin. That was such a comprehensive information. I know that our audience are very happy, and we do have a lot of questions for you. So let me begin by the question of Damilola regarding your personal view on tobacco harm reduction, and what do you think are the considerations that should be put in place if you're doing a tobacco harm reduction?
Sorry, Verna, bear with me. I didn't get that question very well.
Okay. So the question is, what is your personal view regarding tobacco harm reduction, and what are the considerations that should be in place in its implementation?
Thank you so much for that question. There are different harm reduction options for tobacco. Like I said, people have different views and perception about harm reduction. Some have come to argue that the e-cigarette is not less harmful than the tobacco itself. So while others have said that e-cigarette has correct me if I'm wrong, e-cigarette, when it comes to tar, you cannot associate tar with e-cigarette compared to what it is in tobacco and things like that. So the point is, whichever method that is adopted, that help minimize or reduce the risk to the individual becomes more effective. If someone who is smoking tobacco is using e-cigarette or the gum, if it reduces the harm on the individual, then it becomes a step towards decreased harm and a step in the right direction. That is the way I will look at it. And let us also not forget that it is not about generalizing. It is about what is most suitable for individual to minimize the risk, to the health of the individual and other associated risk. Thank you. Please let me know if my response is not in order. I didn't really get the name of the colleague who asked that question. Thank you.
I think that was really great, and you have actually raised a good point in terms of not all substitutions are initially like something that we should adopt because we don't know, like e-cigarette, right? It's unrestricted at the moment, so we actually don't know what would be its long-term consequences. It doesn't necessarily mean that it could be less harmful, but we actually at the moment it's still a work in progress. Now George has a follow-up question regarding in the same context with regards to harm reduction in place for alcohol use, which is a big problem in Africa?
Yes, thank you so much, George, for that question. Again, we have some of these harm reduction options, especially for substances or drugs outside opioid. They are still evolving. For alcohol, for example, you have the disulfiram, acamprosate. These are medications prescribed for people in managing cases of alcohol use disorders. Of course, studies have been able to establish that they are very effective. Of course, that is not to say that they don't have side effects. But the question is, which is better for the individual? So there are medications. So of course, these medications have actually been used over the years, to treat alcohol use disorders. It's still more of well, whether we want to say as in treatment on its own or as part of harm reduction, but when these medications are administered and it reduces the harm associated with alcohol use for these individuals, and of course, it is still part of reducing the harm. I think that is the much I will say on that for now. Thank you for asking that question, George.
Thank you. And then we have two more questions from Ejikame. He asked about how are the traditional healing practices integrated into harm reduction for addiction, for substance use disorders?
Yes, thank you so much, Ejikeme, for that question. You see, the challenge with the traditional practices is that the efforts are not scientifically, presented, to see what is behind, the traditional approach and so on. But I'm always happy when questions like this are asked because it helps to draw attention to areas that we may not have been focusing on as far as global interventions are concerned. So I will always encourage, showcase or sharing experiences from the tradomedical or traditional approach to intervention so that we can learn from it and even replicate them in such way, one will learn from how effective they are. But if you ask me from what I've just said now, because of this presentation, any step, towards decrease in the risk associated with drug use for an individual is a step in the right direction. And again, let me also link it with the point that Veronica just made. Until we eventually evaluate such interventions to see whether it has actually reduced the risk or even added to the risk, one may not be able to say. So if traditional practices are there to showcase and there are evidence that over time that they have helped to reduce the risk, then that becomes great. Thank you.
I think that you already responded to the legal barriers. This was part of the presentation. But one interesting point that Ejikame raised is what are how about stigma in harm reduction? So what do you think are probably how is it happening? What can we do? But you did mention a lot of strategies, but I think maybe his point is about what are the roles that stigma play in terms of implementing harm reduction?
Yeah, thank you very much. Okay, the role of the stigma issue, like I started the example from the Nigeria drug law, also the National Drug Master Plan for South Africa. You will see that how the society interprets a subject, we interfere with how practices about such will be carried out. If the society sees drug use as a criminal issue, as something that should not be tolerated, as something that is against the law, therefore, whoever indulges in it should be punished. The tendency is that the society will see that we are carry along with that. But if the law says, for example, that look, people who use drugs, they have health issues, they have health challenges, and should be treated along that line, then it will help to reduce the level of stigma. I can't remember. I can't remember in Nigeria, for example, where I come from, that people who have high blood pressure or who are diabetic, that they are being stigmatized. I can't remember that. They are not being stigmatized because they are seen as people who are sick and need medical attention, because that is what the law, that is how they are recognized. So if how people who use drugs are seen is different from health perspective, then it becomes difficult not to for them not to be stigmatized. So that's why we talk about public health approach. So let us promote public health approach that helps define, the status of people who use drugs, so that the stigma will reduce. And again, stigma, I mentioned it earlier on, now in some centers, it is actually reducing because the practitioners are getting more educated in how to handle cases of substance use disorders and things like that. But before now, you even discover that even the practitioners or the professionals even stigmatize people who use drugs. So the stigmatization starts from you and I. That is everyone knowing that people who use drugs should not be stigmatized. And that helps, gradually get them. Thank you.
Thank you. It's a top-down and a bottom-up approach. So let's give Dr. Martin a very big hand. So thank you so much for sharing your expertise with us as well as the audience. And I am very pleased to let you know that Dr. Martin actually gave us permission to share his presentation. So we will email it to you. And if you would like to know more about ICU DDR and all of our events, please like our Facebook page, ICUDDR, or visit our website at www.icuddr.org. So thank you very much, everyone. Thanks once again, Dr. Martin. Thank you for spending your day with us. We'll see you again to our next event. So have a good day. Bye.
Thank you. Bye.